Consistency is the key in surgical outcomes, and so is the case with difficult cases which I operate. This is one individual who had a dense cataract along with a floppy iris, and as you can see, this is the kind of pupillary dilatation which we could achieve in the OPD. The cataract was so dense that this is the fundus photograph, which is not at all providing any detail. A B scan was ordered and which was apparently very much normal. So the surgery was scheduled, and this is where we are starting the surgery. The pupil has been dilated and this is little better than what we had in the OPD, and we have started the incision at the steep axis, which is at 170 degrees, and we are also planning to have opposite clear corneal incision so as to neutralize the pre-existing astigmatism without the use of toric IOLs. Old patients are usually hard of hearing, and so they are little less cooperative, but they are less apprehensive at the same time. So if they can understand what is desired, they are able to control their emotions and they can cooperate better. So here you will see the moment the patient could understand what he is supposed to do, he was immediately aligning the eye to the microscope illumination light. The viscoelastic gel has been instilled, and at this moment the pupil size is something like 6 millimeters, and the microscope is again being adjusted, and I noticed that once I had pulled up the microscope far away from the patient was able to recognize the source of illumination better and fixed better. So we are proceeding for capsular access, and this should not be a challenge in these cases because these cases have a capsule which is not very elastic, and it is not very common to have the capsule run up to the periphery, and it is easier to tear it away. So we are having an uneventful capsular access. The capsular access has been done, and at this moment we can see the pupil has reacted to this insult and it has come down to a little smaller size. Making a side port, and at times the side port may be so discreet that it may be a difficult task to recognize where the side port is, and you just see that. Actually, I am sharing these unedited videos now just to share that what goes on during the surgery, and every small or large nuance is captured in the video and shared alike without compromising any portion of the video. Proceeding on to phacoemulsification once the hydrodissection has been completed, and this is a mini flare tip which I suppose that it provides me with better holding and more focused ultrasound energy delivery. And here is the interesting part where I seem to have missed the side port incision site because it was so nicely made that it is just impossible to find where it is. And more so, there was no oozing or the limbal blood vessel were not damaged, so it was very difficult for me to find out where is the side port. So I was at the moment not sure whether I had made it, but finally I could trace the outline and we have started the phacoemulsification. Aspirating the overlying cortex, and at this moment we can see the movements of the iris, a fluttering of the iris along with the fluid movement gives way that this is a floppy iris syndrome, which is going to be a little difficult surgery. However, one thing which I appreciate is that these iris do prolapse into the side port and the main wound, less commonly into the main wound but more commonly in the side port, and I am not complaining about it because it provides me with a good view because that portion of the iris is pulled away, and it provides and aids something like an iris hook, keeping the iris away and providing me with some gap and some enlarged pupil so that I can have a view and we can proceed with emulsification. And in these situations, the iris which gets damaged because of being pulled into the port is not very great, and we have consistently seen this in our previous videos. And I will share few links here which will indicate the similar situations which have been handled by me, and we can have the different flavors of the same kind of situation at different moments. And this is what I like about challenging cases. Routine cases pretty much are non-challenging, they don't provide you any thrill or any new adventure, so little rush of adrenaline and some challenging case is always welcome, so that you can learn and improve upon your surgery. Here we can see the nucleus is consistently being hidden behind the iris, and the side port instrument is more active compared to the main port instrument, that is phacoemulsification tip, in manipulating the pieces so that they are aligned to the phaco tip and they are emulsified. One very important clue here is that once the piece has been emulsified, at that moment one should always consider the iris would be ready to come into the aspiration port, so that one should keep that tip away from the other end, other diameter diagonally opposite surface of the iris. We can see the major portion of the nucleus has been consumed, and this is probably the last piece, and just again aligning the piece so that it is better aspirated and occlusion is achieved, so that the piece can be emulsified with optimum amount of energy usage. One has to keep the movement restricted in the center so that not to engage the pupil or the iris surface. Once the nucleus is gone, we have to come out with the irrigation off, so that there is no increased pressure and the iris prolapse can be reposited back. Now here we can see that there is a epinucleus along with a sheet of cortex which has been left behind, and this will again require a lot of effort, and this is usually the situation where usually the posterior capsule integrity is compromised. However, the epinucleus, if it is seen in the center, it is easier to aspirate, but here we can see the anterior end of the lens matter fiber are all hidden behind the iris surface. So one has to go behind the iris little deep, try to engage the epinucleus, which is now shaped like a bowl, and then aspirate it and pull it to center. If not possible, then one can always resort to using another tool which can retract the iris in various quadrants, so that one can engage the epinucleus and mold that or bend that bowl so that it is the margin is available at the center to aspirate, hold and remove. So this is very effective technique, bimanual technique of pulling away the iris so that the underlying nucleus or epinucleus, or for that matter even the cortex, can be seen and differentiated from the capsule and aspirated safely. The epinucleus is little notorious because it is a thick plate which is difficult to mold, so one has to really remove the peripheral part of the epinucleus, then only it is possible to remove whole of it. Here we have some amount of cortex which is left behind, and which again is being visualized by lifting the iris up, and in this process one has to use the second instrument very effectively and safely. Once the cortex has been removed, we can also keep an eye on the surface of the posterior capsule, which can be harboring few portion of the fibers, and we can polish it just using the irrigation aspiration tip. Again coming out of the chamber after switching off the irrigation, and also at the same time repositing the iris. Leaving the anterior chamber with some amount of fluid just to maintain the anatomy of the anterior chamber, inflating the anterior chamber, and before that one has to deflate it so that the iris prolapse can be reposited back. Now we are ready for implanting the intraocular lens, and I must inform that this is single piece hydrophobic monofocal IOL from Appasamy Associates, and this machine also is from Appasamy Associates, and this is turbo orbit machine which has capability of posterior and anterior segment surgeries. Small pupils, so small that we can see that the IOL is being captured into the pupil size. One has to really push the IOL back into the posterior chamber and then dilate so that the edge of the iris can be overcome when it is opposing the movement of the IOL to be dialed. The anterior chamber is having hypotony because of leakage of viscoelastic, and at the same time we have some amount of chemosis. But at this moment surgery has been nearly finished. The cornea is slightly hazy, but I think it is because of waiting period exposure of the cornea after the topical anesthesia has been instilled, and this doesn't seem to be a pathological cornea to me, having any scar or any opacity. The iris fluttering is appreciable. However, the surgery has been finished uneventful, and this is the kind of consistency which I am talking about. Placing a opposite clear corneal incision opposite to the 170-degree mark so as to neutralize or reduce the pre-existing astigmatism. The surgery has been finished, and now hydrating the wound, and before that one has to take care that the chamber is deflated, the iris is reposited, and then only one should attempt to inflate the anterior chamber because the iris may flow out. This is the first day post-op picture, and as we can appreciate, the cornea is exceptionally clear and patient also had good visual gain. Thank you.